Hello, good evening, and welcome to tonight's JoyNews National Dialogue. We are live on Joy 99.7 FM and, of course, on the Joy News channel. Thank you very much for choosing us. Now, tonight, we gather to confront the crisis that has been quietly suffocating our nation. A crisis that knows no boundaries of age, class, or even geography. We speak of the Ghana opioid crisis. Now, the chains of addiction are strong here in Ghana, and we believe that together we can break them. Over the next 3 hours, you and I are going to be delving into the complexities of Ghana's opioid crisis, exploiting and exploring solutions and seeking answers. So why don't we get started? Tonight, this conversation is aimed at corralling all the thoughts and ideas that we need to build the blocks of solutions to the opioid crisis. We're breaking the chains of silence and stigma, and we're doing it together. Here in Ghana, we want to build a community where we can be free from opioid addiction. And to do that, of course, we have to have this all-important conversation, breaking the chains. Ghana's opioid crisis.
Drugs being abused are opioids, popular suspected cocaine, marijuana or weed as locally known, among countless others.
We have about 276,000 youth have been exposed to this use of opioids. Mr. Speaker, rhetorically, Mr. Speaker, the new opioid substance is what we call red. Mr. Speaker, we need red.
In the next 6 months, if you are able to do something for me, I'll be so happy. And I know the Zongo Menshia Divisional Commander is here. You know, we have a place in Kumasi here around Alaba that is so unpopular. They call it Tinker. That's the task that I want to see. That to welcome me, to show that the Interior Minister is from this region. I want Tinker to be a thing of the past in the next 6 months. And I'll be very, very happy.
Our journey takes us deep into the heart of places tagged as drug hubs, beginning with Tinker Island at the Alaba suburb of Kumasi. This hub has, for decades, defied efforts to be eradicated. I have met these 3 addicts, leading me into one of the many ghettos in the island, but they demand 10 Ghana cedis before taking the risk. They tell me that navigating the area requires more than just a map, but a deep understanding of its unwritten rules. Finally, we have been granted the permit to speak to some of the addicts. I begin with 26-year-old Rich Diddy, not his real name, who is already holding 2 tablets of opioid. This will be his second take for the day. He tells me that he started this in class 6 at age 13 after his friend introduced him to Tinker Island. What drug is this?
This one is a red.
Red.
225.
225.
Red.
Why?
This one is they call Unim Red.
Unim Red. Why do you take red?
Because I used to work. It make me work hard to do something like the thing I cannot do itself. I can do it very hard.
For 13 years now, Rich Diddy has been a consistent abuser of opioids, cocaine, marijuana, among others. Seated next to Rich Diddy is 40-year-old ghetto lord, not his real name, who has been into drugs for 15 years now. Despite being a father of 3, he tells me his wife has rejected him because of his addiction.
I told me no joke. Yeah, where cigarette? I rough man.
I didn't know.
Tell me no. I'm putting me there, kakra. But at long last, I'm my emre. She say kura there, I'm my boy kura, my baby woo.
Baby woo.
Na dey kwe dey opa no dey.
Unim say o baby woo na wono.
I say so manya mo bia me ntimi fa for so nyai.
Ntimi njai.
You be boy kakra.
It's time to engage the leader of the ghetto. Unlike the president, he performs the ceremonial functions of the ghetto. Over here, he serves as the supplier. He sets the rules and controls affairs, just like a ruler in a crumbling kingdom of broken dreams. According to him, there are checks in the ghetto to ensure that everything is in order.
And so in the ghetto, they have leadership, and then the hierarchy is very much important that you cannot skip. The ghetto leader himself is here, and he takes them through everything that they have to do, the regulations of the ghetto, and the ghetto president is also here, but the leader operates and gives out the drug.
Sorry, I had the necessity, no, say I saw dinty, maybe I have no swim, saying I'm and they sorry, so I say I make sure, say, upon sending a tibia, ya befa prayer, near prefia, near Cia. You hear one first sooner, oh, yeah, that's why in how I basically know I had Akasa, and I didn't know sooner. I saw the Juma and a bed, yes, listen, I'm meeting me a change ye. Now you're free, but you make sure, say, being fire and sign free, baby, and at the end, I
He shows me some of the substances he has on his high table.
No be cheche de oyina chena we are den
so obi a won say nsuo enye hwe so say cigarette ya na we so e ma no oba bi ho no say bi ni hia ujimi say oble yeso ma ne pe pa yes say you be the more ba na wa we aye we yin say game na dey akoso we so yo nyema mi say we dey as a book bi a yo no many politics aduane we say bi enuane bi a yedidi na ye dey ewom.
Knowing the repercussions of his action, he is worried about young people abusing drugs. He shared an advice.
Rankwa no mo ba no tin fo na mo ba na man enya man no go na is dangerous. Apa no ho afrifie ono kofi o ma mi busansa adwa 5 cd afuma mi nkodi de ona me jenti mi sire o ma batan wi am mani nko omma ho afuto ntama no mo de maye no ya amfa mi desi akwa metra o se mi se mi supa no pa akwa mesu meto na mi su bebe kubolo life mi de mi sire o mo trama do drug we and sand and makotin bia any circumstances bia ndem dinyam din siro mo de ma mintu me chewe no na enyes ase we ne hye mintu mi amini ndem slepa mi amu nyina min se obi adwuma min che obi akono de mi dem se menye no ho nti menye no ho na America no se wunya no ho ya be de me pane se wo so o be menye no ho se o ma ne hye no nyam ne timbe hwe o ma me ne o ma ene wonu amu.
Veronica, not her real name, is one of the addicts receiving treatment at Cath. She got hooked to drugs after her ex-boyfriend introduced her to it in Accra. Under the condition to keep her identity anonymous, she tells me how it all started.
It was through my ex-boyfriend. I was at Accra, and he was also a driver to one politician. So like the girl was having money. So anytime like I go there, we feel like we're having sex. Just want to get high. And when I started with cigarettes. That's for more white. Not knowing like you just mixed the cigarette with the drug. So anytime I just take the cigarette, it look different. If I just get out from that side, from his side, I go and buy myself my own cigarette, more white. I take it, the taste also looks different. So one day I asked him, what's inside the cigarette that I used to give him? He said, oh, it's this. It's cocaine. It means I took it for 2 years.
In a very sober mood, she admits that the recovery process hasn't been easy.
Hey, suffocation. Let me say so. The way I'm suffering, you can ask the madam, the doctors, and the patients around here. I don't sleep at night. And even there's some fusion, if they put it on me, I will cry throughout before the fusion will just went up. It's like there is a soul inside my body. So anytime the fusion gets to my body, then it just starts to itch me.
Kenneth Edukwachi is a pharmacist in Kumasi.
These drugs are deadly and we have to be careful. We have to get a regulation to help us regulate these drugs very, very well. Very, very well. Because there are people on the market who are selling it without any knowledge of the opioid. We call them opioid naive people.
We used to buy those things. We are insane. Because going to buy something that's wrapped, you don't know what's inside, you don't know the quantity, you don't know how it is. You just take money, go buy.
While this doesn't really answer the question, the Ashanti Regional Director of NACOC, Samuel Yeboah, underscores the role of neighboring countries in this crisis, noting that Ghana has become a transit point for drugs produced elsewhere.
Recently, we've been making some arrests at the Kotoka International Airport. I must say that, this is one of the indicators that point to the fact that drug trafficking is on the increase, because the more people try to cross the airports and they are arrested, it just tells us trafficking is on the rise.
Excerpts there from Deadly Doses, this past Monday's Hotline documentary produced by Nana Boachi Yadom of Love FM, which explored the opioid crisis in two communities in the Asante region, particularly Tinker Island and Columbia. Fascinating stuff. If you missed it, you can still find it on our YouTube channels to watch. Here at Joy News, we consider this to be a priority conversation, and that is why we cannot ignore it. We need to understand the size of the problem, we need to explore solutions, and find a way to break these chains. So let's get started. I'm joined by my colleague Kofi J from the Joy News Research Desk. Kofi, always a pleasure. What exactly have we gleaned about the size of the problem in numbers?
Well, so we need to look at it on the global perspective, and we are talking about some 316 million people using drugs globally. That's about 10 times Ghana's population. And what makes it scary is the fact that if you look at it between the last 10 years, we've seen the numbers going up by some or more than 28%. And it is finding its way in Africa and then also West Africa. But if we decide to break this down, you will know that opioids currently becoming a thing, and because of affordability, people are currently looking at that and not even considering cocaine. Because if you look at the share, for instance, what you have in that light green is the abuse of cocaine, 2% in terms of the number that we saw, 4% going to ATS, and opioids in red, obviously, about 31%. You have cocaine about 3%, and other drugs also hovering around 30%. So you see the mammoth share that opioids has in this, a donut chart that we are seeing. And this is Africa's problem. And in fact, if you're looking at it on this heat map that we've been able to get for you, you will know that if you look at this area, for instance, look at Africa, keep focus on Africa. If you find anything in green, we're talking about cocaine, and anything in red, we are talking about opioids. And you can see this circle here and that heat map where the red zone is usually in western part of Africa. And talking about the western part of Africa, we're also talking about the coastal areas or the countries that are along the Gulf of Guinea. So we're talking about Ghana, we're talking about Ivory Coast, Togo, Benin, and definitely you can't talk about this without bringing on board Nigeria, which if you look at this map as well, you will know the routes in terms of the trafficking of these opioids. Where are they coming from? You have in the center stage, the south and west of Asia. Definitely you can talk about India and other countries that are producing these opioids. They move from this side of the world, goes to North America, not just in North America, but it also finds its way to Western and Central Africa. And then also we traffic some of these things from also Western Central Africa to Europe. So what you see is that if you look at the concentration in West Africa, for instance, it is, I'll show you a chart and you understand why we are beginning to feel the heat. Because already the concentration was around Nigeria, Chad, and other countries. If you look at it on this perspective, where Cameroon was also in that picture. But gradually, you're seeing the bubble, the red bubble in terms of the seizures moving from Nigeria, where the concentration is, towards Ghana, and then Ivory Coast and other parts of West Africa, including Senegal and Guinea. This is why it is important, and this is why we are currently feeling the heat, because countries like Nigeria and Co. have all been through a series of episodes in terms of this use of opioids. And you can find it there. The focus is on West and Central Africa. I mean, if you look at the total map of Africa, a bit clean when you talk about the central part or the southern part of Africa, but the concentration, Kojo, is in the western and central parts of Africa. And talking about the western parts of Africa, we are closer to Nigeria, closer to Togo, closer to Benin, and also Burkina Faso. So definitely you see the bubble moving from these countries towards us, and why we are beginning to currently feel the heat. Let's talk about the evolution of the use of drugs or drug crisis in Ghana, because this is not the first time we're experiencing this. It's important to talk about the historical analysis. And from 1990 to early 2000, that is when we saw the use of cannabis, alcohol, and heroin, dominating in our country. Fast forward, we move on between the 2000 and 2010s. What you see that we move from cannabis now, talking about Ghana becoming a hub or a transit point for cocaines and heroins. Then you look at 2015 onwards. That is where we talked about the non-medical use of tramadol and other drugs. Not just ending there. If you add more, talking about 2018, government then decides to ban cocaine, syrups, and other tramadol uses. That was because we had moved from the use of cannabis, and you saw in that chart that even in, looking at it on the perspective of Africa, cannabis was actually shrinking, where the use of opioids was actually increasing. Cocaine, possibly because of the cost, just about 4% in terms of the African story. And 2018 onwards, this is where the story of opioids actually started. So it's been in the scene for quite some time, and that is why it is important to have a national, dialogue about it. And these are drugs that you can use, and in Ghana, they are accepted doses. If you look at, if hovering between 50 milligrams and 100, milligram. But if you go on the streets where these drugs are actually abused, you see that they fall, way above the range that has been given. You have some using the reds, that is about 120 milligrams. Some also use, this is what the famous one, 225, and then also 250 milligrams. So you see the accepted range is 50 to 100. But if you go to the streets where this is being abused, you're talking about their own range of 120 to 250. This is why there's a national crisis and why we are having a dialogue on it. Now, let's look at the seizures so far between 2020 and 2022. How many have we seized, or how much have we seized so far? We are talking about some 84 million grams.
In 2 years.
In 2 years, Kojo. And you see the trajectory or the trend, and you understand why this has become a bane on the country. We've moved from just about 8.7 million grams in 2020, talking about 59, almost about 60 million grams in 2022 alone. So you looked at 2 year span, or let's say 3 year span, and you were talking about almost 85. But what you see is that if you look at the rate of growth or the change, how we have been able to move from 15.5 million grams, million grams to almost 60 million grams is something that we need to talk about. It simply means that that heat map that I showed you, where we are gradually becoming a preferred market for some of these opioids, that's why you're seeing the sharp increase in terms of the seizures from 15.5 million to now talking about some 60 million grams of drugs that have been confiscated so far. Let's look at the recent use of and tramadol busts that we've seen. we have about 34 arrests so far. And talking about, I mean, the links to 28 packs of the 120 grams of the red, the 225, and then also 250. I mean, but just look at this distribution. What you see that in terms of the range, the maximum has the highest number of packs that was actually, seized, which means that people are currently moving from the lowest of their own range now looking for more of the highs, right? Which means that people are demanding for the 250. They want to get high. They are moving, ladders, and they really want to get high. So you see the distribution of the arrests so far. In terms of adolescent, the reason why this is important is because we are talking about our youth. And you have about 6.5% of the Ghanaian youth aged between 10 and 17 years using tramadol.
That is scary.
And this is a percentage. Maybe you say, oh, just about 7%. But if you look at it on the tangent of nominal numbers, Kojo, we are talking about 426,000 people, or just people, kids or adolescents between the age of 10 to 17 years abusing tramadol. And you ask yourself, the last time we had elections, if you can recall, the 2012 election and the number of votes that it took a presidential candidate to win, and look at 426. That's about, let's say, it's more than our population, just about 10 times more than our population. This is actually in thousands, but if you compare it to the what I was telling you about, the votes and all of that, this is a big number that we need to talk about in terms of the percentages. And talking about hotspots, which areas are we looking at? I'll show you a map very soon, but the urban areas, definitely the focus. And I was telling you about that heat map where we were able to locate the coastal countries that were abusing red. And Ghana was one of them currently because of the influx coming from the other parts of West Africa. Greater Accra is a big hotspot. Kumasi is one of them. Secondly, Takoradi and Tamale. So it looks like almost all our big cities are currently mapped as, big hotspots. If you look at the rural areas, we are talking about Drapa. A place like Drapa is also known for the abuse of drugs, and also the Wassa and Menfi, also one of the areas in that the hotspot map that we are looking at. This is the map of Ghana. Let's try and plot for you to understand what we are talking about in terms of the hotspots. And you can see that almost every part of the country, especially in the southern part of Ghana, it is almost everywhere dense in terms of the abuse of drugs. And these are the hotspots that we are talking about so far. But definitely you have about 75% global use of opioids actually leading to death in terms of the drugs, death associated with drugs. 75% of this is coming from the use of opioids. And currently, we are gradually becoming a component of that big number that we are seeing. And that's why it's important to have a national dialogue. So I showed you the global perspective. And we've also seen the heat map that shows that since 2018, there is that rise in the use of opioids, especially coming from the other parts of West Africa and finding its way into other West African countries like Ghana and, a place like Ivory Coast and Senegal that used to be an alien. We've seen the wave blowing across, West Africa, and Ghana, unfortunately, has been caught in this wind. And we've also seen how gradually Ghana is also becoming a marketplace for the trading and use of these drugs. And we also showed you the quantum of our youths or teenagers between the age of 10 to 17 years, over 400,000 of them currently, possibly caught in the trap of using this drug. But I will end with this in terms of our situation so far. We'll talk about the economic cost of this. We all know there are some people we saw in the documentary who said that when they take this, it makes them strong, they're able to work. But we all know that after that period, you'll be back to, square zero and all of that. So you see there's an economic cost attached to this. We just saw that Ghana Statistical Service, labor bulletin today, and about 1.42 million of our youth in the last quarter of 2024 did not have jobs. And usually, if you do a breakdown of those who are actually abusing, this drug, although you have high-class people also involved, most of these people who abuse these drugs are people who do menial jobs, and some of them are actually underemployed. The little they have, they spend them on these drugs. And so there is that economic cost associated with the use of these opioids. And so that is the story so far. I mean, these are the numbers that we know, and definitely I know that when you engage our guests, they will bring proper perspective and try and help us tell the stories behind the numbers that we have seen so far. But definitely, there is an economic cost attached to this. And also, the most important aspect is that this is increasingly becoming a national security threat, Kujo.
You know, it's actually quite depressing just how well Ghana read, right? It's just a scary situation. Kofi's team will be putting up a lot of these graphics on our social media handles so that you can have a visual representation of the discussion you've been listening to if you're joining us on Joy 99.7 FM. All right, well, we have assembled the best. All right. You're welcome back. This is the Joy News National Dialogue, Breaking the Chains, Ghana's opioid crisis. It's a conversation designed to start to find a way towards the solution to this looming crisis that is threatening to engulf Ghana's youth. Let me introduce you to the panel of guests we've brought together for this all-important conversation. First of all, coming to us from the Food and Drugs Authority. She is the head of Substances of Abuse Department. Good evening to Ada Alote Papo. Thank you for making the time. Also here with us is Chief Superintendent Dr. Birgit Neuropenying. I hope I've said the name right. It took some practice. Thank you very much for joining us. Chief Superintendent Neuropenying is a law enforcer, obviously, and a psychiatrist at the Ghana Police Hospital. Dr. Eugene K. Dodoi is the lead addiction specialist and acting chief executive of the Mental Health Authority. Thank you for making the time and good evening. Okay. We are honored to have Kamal Dean Awudu. He's head of education and prevention at the Department of Narcotics Control, which is part of NACOC, the Narcotics Control Commission. It is an honor to have here with us the Minister of Youth Development and Empowerment in the person of the Honorable George Opare Addo. Good evening to you, sir. And we have some panelists joining us via Zoom. CDD's Dr. Kwame Sapong Asiedu requires very, very little introduction on Joy platforms. Good evening to you, Dr. Sapong Asiedu. We also have Professor Samuel Ajololo, who is head of department at the Mental Health Nursing, the head of Department of Mental Health Nursing at the University of Ghana. Good morning to you, Prof. Good evening to you, Prof. Sorry. Now, we have two young men whose contribution to this conversation is vital. First of all, Walter Damien is an internationally certified addiction professional. He's an educator. He's joining us alongside Alan Menz, who is a counselor of Iris Place Rehabilitation Center. Now, both of these gentlemen are recovering from addiction, which means we get the privilege of insider information about what it's like to be addicted to opioids from the inside. That's our panel. Let's get started with the conversation. Now, here's how I'd like us to structure things. First, let's educate ourselves. Let's understand what is in these opioids. Then let's understand what they do to our bodies, and then we'll try to investigate where they come from, why it's such a big problem, and then we can start looking to solutions. So if you don't mind, Ada, I'd like to start with you. Help us understand. When you take a typical opioid, let's say Wunim Red, 250 milligrams, what is in there?
Okay, so when you take opioids, when we talk about opioids, we are talking about a class of drugs that are coming from the poppy plant. So we have those that are naturally obtained and the ones that are synthetically derived from the lab. So when we look at examples of natural opioids, we are looking at heroin as a natural opioid. We have morphine, codeine. And then when we talk about the ones that are synthesized in the lab, we are looking at tramadol, tapentadol, fentanyl. So those are the two classes under the opioid. So it is not just one class of drugs. A lot of things come from it. But the most popular one that we know are the heroines. And the opioids medicinally are used for the management of moderate to severe pain. So these are drugs that we can't just take off. They are essential for pain management in the clinical setting. And they act to relieve the pain, but in doing so, they release what is called endorphins. It triggers the release of endorphins, and that is what gives us that feeling of excitement, happiness. So people take these opioids and they get the euphoria associated with it. So it gives you that feeling of, okay, I am no more in pain, I am happy, I feel I'm in a good place. It gives you that feeling of good place. It is because of the triggering of the endorphins. So that is how come people get excited when they use these opioids. Traditionally, in the clinical setting, when clinicians prescribe these opioids for you, it is given to you for a period, for a condition. No clinician, because of the psychoactive nature of the products, will put you on opioids on long-term basis. It is normally on short-term, except for exceptional circumstances. They normally will not give you a long-term because they know the potential to get addicted is high. And in the submission made when you were doing your presentation, you noted that in Ghana, the legal ones in terms of tramadol is 50 and 100 milligram. And as mentioned earlier, between 2018 2019, when we had the issue of the tramadol abuse, there was the need for us to get an EI to cause the ban for codeine-containing cough syrups. So currently, codeine-containing cough syrups are banned in Ghana, and tramadol was included to the list of controlled substances. Internationally, tramadol is not one, but it has been reclassified as such to enable us to put in the necessary regulatory measures in place to regulate that space. And then recently, we got the issue of tapentadol coming in. Currently, the FDA does not have any form of tapentadol registered for use. It is not in our standard treatment guidelines for use in Ghana as well. So any that you see on the market is not a registered product.
So it's all illegal at the moment?
Currently, yes. All the strengths you are talking about are illegal.
Right. So this Wunim Red, which group of opioids does it fall under, and what's in it?
Okay, so the ones we've been able to obtain, we also tried to go out on the market the way you also did your investigations. The ones we found so far, the label claim is tapentadol.
Right.
So it contains tapentadol.
Right. Dr. Dodoy, I would have thought that anything that kills my pain is good. But obviously, we can see from the documentary that those who have exposed themselves to these drugs for a long period of time are suffering negative effects. So what else does this drug do in your body? You know, what else does an opioid do in your body apart from killing your pain? What does it do that causes such harm?
Yeah. Before I get to that, I got a statement from my elders in Nunya Dume. They said, in the kingdom of Nunya Dume, there was once a bitter tree whose fruits shone bright like gold. They were like commonly coming from the Middle East, where Osama bin Laden. At first, the taste, the fruit gave strength, courage, and even laughter. But those who returned for more found that their hands were no longer free. The fruit chained them. Body and soul, and the whole kingdom of Nunya Dume began to mourn its strongest sons and brightest daughters. Today, Ghana faces its own bitter tree, the opioid crisis. It is no longer a distant story. In our communities, on our streets, and in our schools, young men and women reach for red, tramadol, cocaine, codeine syrups, and stronger poisons in search of relief, energy, or escape. They cannot rid themselves of red after they've fallen in the red. And this is not red, the gobe that we eat. Instead, they find themselves bound by addiction, by stigma, and too often by silence. This is the chain we must break. As a nation, we must first name the challenge clearly. Opioids are destroying futures, fueling mental illness, and tearing families apart. What was once whispered in Canada is now a public crisis. Overdose death rise, productivity is lost. Too many of our youth see no path but the bitter fruits. But the chains can be broken. We have broken many chains before. We broke TB, we broke HIV, we broke Corona. What we need is a public health response, not a punishment. Ghana has got CHIPS compound, district hospitals, schools to reorganize so that we can have early signs detected and intervene and heal. Solutions do exist, regulating illegal supply, expanding rehab centers, training frontline workers, ensuring an unlock zone, which we'll talk about later, for overdoses. But solutions alone are not enough. We must approach with unity. Chiefs, pastors, imams, teachers, parents, and the media all have a role in turning the narrative from shame to support. In Ecclesiastes 4:12, it said a three-strand cord is not easily broken. But the ancestors of Nunya Dume taught that a rope tied together by many strands can never be broken. If Ghana ties its strands, policy, healthcare, education, community, and compassion, we can break the chains of opioids. We can save not only individuals, but the very soul of our nation's future. Let us not wait until another generation is lost to the bitter tree. Let us act together now. For every young person who still believes tomorrow can be brighter, and for every family waiting for their child to return home free. And this is from the stammering linguist of Nunya Dume. The challenge, as I've put in this piece about opioids, is that so generally chemicals that go into our body may have one target. So the target that we want it for is for the pain. But sometimes when you want to cut a tree, wrap around a stone, it's quite difficult. You still hit the stone. So drugs are not smart. They don't go for the target you have hit them, you are trying to give them for. So the same drug can relieve pain. That same drug can relieve you or give you a feeling that we get from sex, from food, from water. So that pleasure you get, the drug can give you that. And that is what, Mr. Papa said, psychoactive. So psyche means mind. So it's able to activate your psyche, your mind, and then you feel high. So the drug is a painkiller. It makes you feel high. Tramadol is also very interesting. It delays ejaculation. Quite. Yes, so the young man can go long journeys.
Right.
Yeah, so if you have a drug, that in itself will give you pleasure when you take it. When you have sex, you can have for a long time without ejaculating, meaning you go for a long journey. And then when you are tired, you feel pain. The drug is a pain, reliever. So when you go for the long journey, you don't feel tired either. And these young men have got young hearts which can take the extra burden. So it kind of gives them every benefit you would want. So in their minds, the drug made them strong because now they can do things they couldn't do. And it's unfortunately, they feel drowsy, but they don't sleep. So when they go for galamsey, the mining, it also keeps them awake and they don't get tired. So that is what makes them think they kind of get strength from the drug. And unfortunately, very unfortunately, the mind is saying that if you take drugs of abuse, tomorrow it will demand more because what you took today will not give you the same high tomorrow. So with time, you need more. And when you start using it for a long time, that's what we call tolerance. When you start using it for a long time, you can't stop. When you stop, you fall sick. What we call withdrawal syndrome. And that for opioid can kill you. If you stop at once, yes, that can kill you.
This is an important point. What we're saying here is that the goal that we are aiming at of actually stopping addiction has a potential threat of killing those we're seeking to help.
Sure. So before they stop, they need to see a professional. There's a way to stop. So that is the challenge. If you take too much of it too at a time, you can get overdose death because the drug would depress your respiratory center, meaning that you start breathing very slowly. So you don't get enough energy or oxygen into your body to use. So you more or less suffocate. So that is how dangerous the drug is. So too much of it will kill you. You use for a long time and you stop it, you fall sick. That can also kill you. So the best thing is don't start. And unfortunately, it's a disease of young people. I mean, we have it up to about 1 in 4 people who start drug abuse before age 19 will become dependent on it. 1 in 9 who start after age 24 would ever get dependent. So there's something about the young brain, the developing brain, that is not able to synthesize and use drugs. So if we are able to protect our young people for some time before they start using, we stand a higher chance of they not getting into it. But unfortunately, we are not protecting our young ones. And I think as a nation, we are failing them. Yeah. We need to do something more. We need to do something better. And that is why this dialogue is so critical. It needs to be had.
I appreciate that. Kamaldeen, you sit at NACOC, and some of the data that we've shared today, it comes from the work that NACOC does. We seem to know a lot. We know how much they're taking. We know where they are. We know who they are, which demographics they fall into. We know what it does to their bodies. But we don't seem to know where the drugs come from. Because all of the arrests we hear of are of users, not dealers. Where are the dealers?
Oh, thank you very much for this question. I'm happy that my question has been drifted from the pharmacological discussion to implementation. When it comes to the issue of narcotics abuse, NACOC look at it from a holistic point of view, from a balanced point of view, from the enforcement perspective, and from the demand reduction perspective. But the two are not mutually exclusive. You can't handle one without the other. They are complementary. So what we do as an agency is to be able to identify the key risk factors that drive some of these things. And if you're able to identify those risk factors, it makes it easier for you to proffer solutions or mechanisms to bring it to the various minimum. And one very important risk factor for drug use is, some of them are environmental, others are personality-based. The environmental ones are the ones that are, the immediate environment for, let's say, a child or the youth. For instance, if a child is growing up in a marginalized and poverty-stricken community, that is a very high risk factor for the child to become a drug user. And then secondly, a child who grows up in a home that he or she is being maltreated, stressful conditions. So we try and identify some of these risk factors and then proffer solutions. And that's what we are doing at the Narcotics Control Commission. So communities that are marginalized, children growing up in such communities feel that pain because they are deprived of economic resources, healthcare, education, and so on. And such kids growing in such communities at a point become so frustrated, and the pain of that frustration and stress are all risk factors because they use drugs as a coping mechanism for those emotions. So we have started a program that, because community mobilization and participation is very, very important when it comes to substance abuse interventions. And recently, I did that with a community called Sabonzongo, a community just close to Abusukai. And I did that with the police visibility unit and then other stakeholders. And these communities, the community themselves did a research, identified the malleable risk factors in the community, and then they presented the findings to us. So based on that, it made it very, very easy for us to proffer mechanisms to be able to do it. And then we entered the community and then made sure that we did an intensive drug preventive education programs for the youth in that community. But when it comes to the other side, of the supply separation side, I think over the past few weeks, you've heard about drug destruction activities that we undertook and involving drugs worth about 2 million that were being destroyed. And then on June 20th this year, just getting close to the World Drug Day activities, we also destroyed several, drugs, also amounting to about 11,500 kilograms of drugs, ranging from cocaine, heroin, tramadol to red, and so on and so forth. And so we focus so much on the implementation, to ensure that the issue of substance abuse is brought to the barest minimum.
Who were these drugs seized from?
We do that in collaboration with the FDA. Madam is here. We are stations at the borders. And so they leverage on our presence at the borders to do the collaboration. So when we do the seizures, we collaborate with them. These are imported through our borders, even though some also come through unapproved routes. So like your presentation indicated, most of them are coming from India. And if you recall, I don't know whether this year or the latter parts of last year, the BBC expose that have been in Tamale indicated that most of these drugs were coming from India. And so it is clear to us where these drugs are coming from.
Which really makes me remain baffled about why we don't seem to have as much spotlight on the dealers of these drugs. Chief Superintendent Nurupenyin, I wonder, as a law enforcer, how does it feel when so much of your work so far has centered around the addicts, those who are sick? They are the ones you seem to be picking up off the streets. We're not hearing about dealers, importers being picked up at the same rate. As a law enforcer, is that frustrating for you?
It's extremely frustrating because, as is, our laws are quite punitive when it comes to substance use, when it comes to drug trafficking. So per the law, we break it down in terms of there's possession, there's importing and exporting drugs, and then there's use.
Right.
So when it comes to the use itself, that has the least punitive measures, because obviously we understand addiction but when it comes to the importation and exportation and the distribution, then we have more punitive measures. However, what has been frustrating for the police is the recognition that somehow when it comes to the courts, It's now a bailable offense. Drug possession and distribution used to be a non-bailable offense, but it's now a bailable offense. So you pick someone up, within an hour or two, they're allowed to go home. And once they are home, following up, getting your necessary investigations, it's a back and forth, and it sort of dies, unfortunately, a natural death. And so it becomes very frustrating on a law enforcement side, where you can definitely see, okay, these are the people, it's a syndicate. You have drug syndicates, very well organized, but it's very difficult to pick the kingpin, and then you end up getting the lowest hanging fruits, which tend to be the users.
It's quite depressing to hear you describe the problem, right? You know, because it sounds to me like as a police, you're stressed out because you're catching people and they are getting bailed, and somehow the bail is making it difficult for you to investigate the crime that you caught them for?
It's not so much that the bail makes it difficult, but you have to recognize that when you're investigating anything, once you're, so say you pick someone up, once they are able to go back into their community, they are able to hide better because we are not tracking the person that we've picked up. So in terms of picking someone up, when we don't get the necessary information to go and do a bigger drug sweep, by the time you get any information, they've gone underground. And so the frequency, that's why I said within an hour or so, someone can be bailed. And by the time you get your necessary intelligence, they've gone underground. And when you're dealing with policing, you need evidence. It's not a matter of, oh yeah, we caught this person and they said person A or person B is a distributor or an importer. So with the lack of evidence, it becomes more difficult to prosecute.
Is it not an option to get the evidence before you arrest them?
So we spoke about getting the lowest hanging fruits. So once again, you meet someone who's a user, you've arrested. That person can be part of a bigger syndicate. But to get that information, to get the evidence, to get the bigger syndicates is where the challenge becomes. So we are not talking about simple drug. We are talking about a like organized crime. And once you're dealing with organized crime, getting to the bottom of it becomes more challenging.
So we know that you've seized about 82 million milligrams over the past 2 years, according to the statistics Kofi shared with us. 82 million milligrams seized, but no dealers prosecuted.
I won't go into the level of prosecution with regards to the dealers, but think of how much is seized. So that should give you an indication of how much is inside the country. We are not dealing with only simply a Ghana problem. We spoke about West Africa. We spoke about things coming in from India. We are not talking about simply this is Ghana. So when we are talking of drug importation and exports, you know that you're dealing with a syndicate that goes way beyond your borders. So sometimes you have heard, we talk about Interpol, but we have a lot of ECOWAS collaborations with a lot of these substance use. For all you know, the main dealer is sitting in Liberia or Sierra Leone or Nigeria, and the distributors are in Ghana. You can pick one distributor, and then like a Hydra,
others spring up.
Yes, others spring up. And so that is where the challenge comes with the prosecution of drug importation and export.
Minister Opariado, according to NACOC just a few years ago, they had estimated some 50,000 odd, users of opioids across the country, out of which 35,000 of them were youth. This is a problem that falls squarely on your desk. How clear is your ministry's picture of the size of the problem? I mean, did you hear things today that were a surprise to you?
Thank you, Kwajo. When I assumed office, one of the first things we looked at was the health and well-being of young people. And so I'm sure you've heard about Red Me Stop. It is one of the campaigns that the ministry has launched. And when we did it, we were gracious enough to have almost all the partners come on board. But the challenge was that we didn't have enough data. there is a lot of data flying around, but it's not data that has been validated. And so what we sought to do was to first understand the problem and then get some data. So as I speak to you, just last week, I got a report from the Global Info. We commissioned Global Info Analytics to look into our tertiary institutions, our nursing training, our teacher training colleges, our colleges of education, and then our various universities and technical universities. They've shared the results or the report with me. I'm yet to meet the president on it, and so I don't want to make it public. But the data the reporter put out and what I am looking at, I was not a bit surprised. We know it is a problem amongst young people, and so we need to find a holistic way of dealing with it. I am not an expert on issues of drugs. Until I got into this space, I was just out there mobilizing young people, and drugs was one of the main things I was looking into. I was at a youth seminar at the UPSA, and after giving my speech and everybody clapping for me, it was time for Q&A. And the last question was, Unim Red. Believe me, I didn't even know what red was. I heard about tramadol, and I knew tramadol had been dealt with somehow, some way. And when the young man asked Unim Red, the whole room erupted, and so it looked like it was very popular. So it was at that stage that I said, let me get some education. 2 weeks later, we launched the Red Means Stop campaign, which is a campaign, it's an advocacy campaign where we are going around and just to do the prevention method, to speak to people and tell them the dangers associated with it. Then we told ourselves that we've asked for data from the Ministry of Interior, shared some data with us, NACOP shared some data with us, even the FDA gave us some information. But the data was not focused on our targets. My target is young people between the ages of 15 to 35. Below that age falls under the gender ministry. Yeah. And so the first thing we asked to do was, let's understand what our problem is, that group that sits with us. I have that report. I'll give you a few bits and pieces of it before I leave. And then we've commissioned another one for secondary schools, all the way to junior high schools. It is when we have all that report, then we'll be able to sit down with all the stakeholders again and tell them that this is what we are seeing. This data is validated, it can be authenticated, and so how do we deal with this challenge? But I must admit, it is a big problem. I have traveled around this country. When I was going around, I was not paying attention to opioids. But ever since I was made aware of it, I try and look around, I scout around anywhere I go. And now I see the problem. And it's because of the awareness. Because that is why I believe that awareness is one of the key things we must do. And that is why I commend Joy FM for giving us this platform to speak to it. Because once I became aware, now I even know people around me who ordinarily I would not have thought would have been using one substance or the other. But when I became aware of the problem, now I'm able to see people and know that this guy, from the way he's behaving, Unim Red. And so advocacy is very important. It is very important that we have forums like this to speak to the problem. Because the truth is that it is even closer than you can even imagine. And everywhere I've spoken about this opioid menace, I make mention of the fact that everybody is at risk. You'll be surprised that even within your studios, if you look well, based on the educations they give, if you start looking around, you'll find people around you who are using it. And like Dr. rightly said, when you interact with them, the kind of things they tell you, and for a young man who knows that it can extend his sexual duration, it is one motivation to keep him going, unless he knows the dangers associated with it. Because usually when they are pitching it to you, they pitch it in a way that is more attractive. You don't get to hear about the challenges and side effects. And so it is a conversation that must be had in churches, everywhere we find ourselves. I've said time without number that this problem is even bigger than the Galamsey problem we have. I met a group from Liberia, they are drug enforcement. They came into Ghana and then they were gracious enough to visit me. They shared some scary information with me. And then I was at one of the international conferences and I met another person from one of our sister countries. within the West African sub-region. Apparently, he tells me that, I don't want to mention the name of the country because of international issues, but he tells me that they have already lost 20% of their youth to this drug menace. To the extent that in that particular country, they even dig dead bodies out, grind their bones, mix it with the opiates, because now the ordinary opiates don't even get them high anymore. Yes. Yeah. And I've seen a documentary to that effect. Yeah. And so that is the problem that confronts us as a nation.
But is there something in bones? I'm sorry, I'm just asking the experts quickly before we come back to the minister. Is there something in bones that creates a high?
Yeah. So there are compounds in bones, dry bones, that when you combine, they have kind of a cumulative effect, a combination of symbiotic effects with the drugs of abuse. That will get you high. We have some also in the steam of gas, fuel, and some from fecal matter.
And teeth. And oh my goodness.
Yeah. So,
Honorable Minister, please continue. When they shared that information with me, I went straight to His Excellency the President and discussed with him. So he even called the National Security Coordinator. So as I speak to you, I'm working together with the National Security Coordinator to even raise funding to be able to go around and run some advocacy campaign, and I'll definitely be bringing all these organizations on board. There is another problem with the fuel he mentioned. A lot of them are abusing fuel, glue. I don't know what it is. I'm not a scientist. I'm just a lawyer. I'm not able to appreciate and comprehend what the substance in there are. But from the reports I have, if I will just share snaps of it. So 59% of our respondents in the tertiary institutions are on one, they call it weed edibles. 59%.
Weed edibles. 15, more than half of them.
More than half. And then the scary part is the shisha and hookah. And ordinary shisha should not have been here. But I understand now they mix some substance with the shisha and hookahs that are in our various drinking spots and bars. That is 49%.
Wow, almost half.
Yes. Prescription drugs, 41%. That is where and these are tertiary institutions. Codeine, cough syrups, 23%. Inhalants, I hear there is something called balloons or something. They blow.
The inhalants are not those ones.
And so which ones are the inhalants?
The glue, the turpentine.
16%. Whoa. And then you'll be amazed to know that 12% of our university and tertiary students are abusing cocaine.
Wow. And crack.
Yeah. And then 11% heroin.
Yeah.
So
it's quite common.
And I know cocaine is expensive. Yeah. I know heroin is expensive. And we even drilled down to the various institutions. So you realize that the nursing training colleges or the nursing health institutions don't do a lot of abuses. Reasons are that because they still operate some form of military regime within the schools. You need permission to go out, but the worst abusers are the universities.
Universities, yeah.
And if I share Legon's data with you, it will blow you up.
Wow.
And so more or less our tertiary institutions are more like epicenters where this, and I understand during hall weeks, during festive occasions on the campuses, it is sold on campus. We even asked how is it easy to get access to it. And you'll be amazed, students on campus actively selling.
Mr. Parado, tell us the Legon.
What I'm saying is, I'm yet to discuss this with my bosses. So I only decided to share a few. But at the appropriate time, in about a week or two, we'll do the state of the Ghanaian youth and we'll put out all these facts. I want to get that of the basic and junior high schools, including the secondary schools, so that it becomes comprehensive, because this is just for tertiary. But I understand the problem is even bigger within the younger generation, based on the data that you just shared. And so till we understand it, we'll be addressing it midway and we'll not be able to tackle it. I believe strongly that the best form of tackling it is from the base, from the roots, with the younger ones. If we're able to put them in a certain bubble and then they don't get influenced then we'll be able to deal with the problem. And so, permit me, I'll definitely come back here again. And one of our key partners is going to be Joy FM when we decide to do a full launch. We've launched the Red Means Stop campaign. And just about a week ago, I saw Kofo Kwade and Co in Kumasi running with the same slogan, Red Means Stop. This is what we want. People who have abused substances before. We want everybody to come out and start speaking about it. Because if you understand the problem, like I said, I was ignorant until I was educated, and now I can see. And so if there is more advocacy and we can all see, we'll be able to know people who are abusing it and then be able to seek help for them. But if we leave it the way it is and we don't talk about it, then we will all find ourselves once. And I understand it's a problem for young people. We will definitely come up with a comprehensive program to deal with it.
Professor Samuel Ajololo is head of Department of Mental Health Nursing at the University of Ghana. Prof, how well equipped is the average Ghanaian healthcare professional to assist an addict? How well do we train our healthcare professionals, and how well are they doing out there on the streets in this fight?
Thank you very much. Good evening to our listeners, and I'm happy to be on this program. Good evening to Dr. Dodoy, who happens to be my regulator, and so I'm happy to be here with you and every other person. So our training of healthcare professionals, and because I work in the School of Nursing, I will speak more to the training of nurses and midwives at the School of Nursing and also at the university level. So rehabilitation or drug addict management, whatever we want to call it, is a specialized field, and it's not a routine practice area where you can just come for medication today and then you go. And so what we do in our trainings is to expose them to the basics of rehabilitation and understanding issues of substance abuse and substance use. But that does not give them the requisite skills to be able to support the rehabilitation. And so at the Ghana College of Nurses and Midwives, they have specialized programs in rehabilitation where nurses who have first degrees in other programs can now go there to become specialists. These are those that have more advanced knowledge, competence, and skills to be able to offer rehabilitation services to all those that will need these services. Otherwise, the average nurse, and I'm sure the average doctor who just graduates from our schools is not equipped to deal with issues of rehabilitation because of the complexities and the other technicalities involved in the whole rehabilitation cycle. So this is my contribution to the trainings we have had. So if we are, as a nation, we want to go to the preventive side, to the treatment side, which I'm not too much in support of, but it's also a necessary evil, then we must invest in training people at the highest level of specialization so that they would be able to deliver the treatment modalities that we need to support the prevention and the fight against opioid crisis and other substances in this country. Otherwise, if we just leave the battle the way it is without investing in those special training and also resources, I'm afraid we may just be talking and talking without reaching any solution that we are intending to actually get. Thank you.
Prof, why are you not so much in support of treatment?
You know, treatment is very expensive. Treatment is very expensive. In fact, if you understand the process of addiction, before someone becomes addicted, it's not a 1 week issue, it's not a 1 month issue, sometimes years, several years. And so to undo what has been done in years requires a lot of resources and commitment. So the best strategy is public health promotion, which takes the arena of health prevention rather than treatment. So the focus and the focus of our discussion as a nation should be how do we prevent even our young people from abusing these substances, rather than thinking of waiting for them to commence the process And are we initiating a treatment process? But the costs will be too much for us to carry. Taking away the economic costs, the health implications, the social implications are just enormous, and we don't want to get there. The minister was mentioning about how many people are taking, let's say, tramadol and shisha. I mean, these are scary numbers. How do we stop these people? Assuming all these ones become addicted, 50% of the respondents become overly addicted, and they can't do anything for themselves. How much money do we have as a nation to begin to treat these people? How many resources do we have to go in there? And that is why I'm saying that our focus should be more on prevention rather than trying to wait for the harm to occur and then we react. We are always a reactory nation. We should move away from reaction to taking proactive measures. And I'm sure maybe as part of the discussion, this will come up. Now we cannot suggest how we can prevent this menace rather than waiting for it to be treated, because treatment is overly expensive. And we, as a nation, we don't have the resources. We must also be quick to add that we cannot entirely stop opioid crisis, or we can stop substance abuse in this country. I think it's just impossible for every nation in the world to say that for me, my citizens, nobody will. It's just impossible. But what we're trying to do is to reduce to the barest minimum the number of people that will be hooked onto those substances. And that is where the discussion I think we should be looking at. For total eradication, is just even advanced countries like US, Canada, Netherlands, UK, they cannot and they are not able to. But at least they are making an effort just to reduce the number of people who get these substances used, so that the cost implications will also be smaller for the nation to bear it. Thank you.
Prof, in a moment, I'm going to check with the rest of the panel to see who agrees with your position that treatment is not the best way forward. But I'm just wondering if your solution or alternative is prevention, education, public education. Are you presuming that those who get addicted do so because they didn't know that drugs were bad for them?
We can say yes, and we can also say no. In fact, just as the minister said, we have been conducting research in these issues for some time now. As I'm speaking to you, we are having an ongoing project far away in Pro East, in Jeji to be precise, and the focus is on substance. These are communities far away from Accra, so we can say that they are under the pressures of economic struggles here and there that we witness here in Accra. But in those communities far away from Accra, we have enormous evidence pointing to substance abuse. For some people, genuinely, they are ignorant. Indeed, if you look at the sources where these substances are coming from, how they didn't get access to these substances, mostly it's from peers. Okay? So for some of them, they have no idea what it means. Out of curiosity, they just want to experiment. They've heard, oh, when you take these drugs, you get this feeling. You get this euphoria, you get addicted, you're able to do this. So they just want to experiment. But in the process of the experimentation, the brain is adapting to meet their needs, to the point where subsequently, if they don't have that substance in their body, they are not able to function the way they're supposed to function. And this is where Dr. Dodo mentioned the issues of tolerance and dependence. So for some, genuinely, they don't know. And for those that know, for some other reasons, societal pressures, they are forced to take on those substances as a way of relief. This is also a bad way to cope. So the totality of the discussion is that yes, some know, some don't know. But to move forward, we need to devise strategies so that those who don't know become aware of the consequences. And for those who know, how do we sort of enable them to positively cope with life stresses, so that they don't see these substances as an easy escape to the challenges that they are confronted with in society.
I want to quickly check with our panel in the studio before I come to Kwame Sapon-Asiedu. Does anyone else here think that treatment is a bad idea?
I don't think treatment is a bad idea. We need to tackle this simultaneously. As we are doing education, treatment is also being done. Because looking at the percentages that we are hearing now, with quite, I think at a point, one of them, 50% of the youth in a particular university are all on these substances.
58%, wasn't it?
Yeah. Are on these substances.
59%.
And that is a huge amount, which has cost to the economy with time, because you're losing your workforce. So there's the need for us to do the treatment, but the education, the preventive measures, the harm reduction programs should also be done as we are doing the treatment.
You see, when it comes to us psychiatrists and for those of us in addiction, for me, it hits the core of what we have been preaching, which nobody hears us. Addiction is a disease. So should we say that we have enough information about hypertension, how to prevent it? So anybody who gets hypertension should not be treated. We should punish them. That is essentially what we are saying. Because if addiction is a disease, nobody chooses an illness. Okay? People fall ill. So to say don't treat when they are ill, I mean, I don't know, the accounts will say, when you be anfama wasia, yem bone chrono. No, so it will be, I mean, very distasteful and wicked as a nation if we don't treat them. It will be as if they caused their own problem. They chose to be sick. I chose to get a headache. I chose to get diabetes because I bought my own sugar and I ate. That is something we are saying because we know ways to prevent hypertension, diabetes, even things like asthma or sickle cell crisis. We know ways to prevent them. So why do people still fall ill from these conditions? Because we are genetically predisposed. There are people born to be addicts. I mean, just are people born to become hypertensives. So it's not because you did all the right things, that is why you are not an addict. Or he did all the bad things, that is why he is an addict now. So in public health, we don't necessarily say that, okay, you cause a problem, so solve it. That is why we call it public health. Because it's a condition that affects many people, we do not let the individuals take care of themselves. The nation or the state comes in and puts policies throughout the spectrum for promotion, for prevention, for primary care, for secondary care, for tertiary care, and for rehabilitation. So we need to do all of this simultaneously. But to say you can't do one and leave the other, and there are approaches to all of them. Just like COVID. Did we say that people who decided to not wash their hands and got COVID, they should be punished? Whilst we're preventing COVID, don't go out, don't mix with people, we're still building centers and treating people. That is how you address a public health crisis. So that is the multi-pronged.
We don't have money.
Well,
we don't have money, so people should die.
No, well, I'm not sure he really meant.
Okay, before that,
meant that no treatment. I think he was trying to
say that we should kind of prioritize the prevention and promotion over treatment.
But I wanted to point out that the fact that 50% of students might use is not the same as 50% are addicts.
Yeah.
So when we are talking about substance use and we are talking about addiction, they are not the same thing.
Yeah.
And so like Dr. Dodoi said, addiction is a disease, so it needs treatment. But when we are talking of substance use, then coming in with the preventative measures and everything that Prof said, then come in. So I think we should not also be so like taken aback that, okay, 50% use. I'm sure many of us here tried different substances. when we were in tertiary, but we are not addicts. So let's just...
Much as I'm tempted to turn this into a confession session, I will move on to Kamaldeen.
Yes. So,
who is the priest here?
I want to understand Prof to a certain extent. I remember, you know, in my initial submission, that's why I said that there's no effective prevention, intervention, or policy that can work without including treatment and the other elements, like harm. But I even mentioned harm reduction. Then what will Prof say about harm reduction? Harm reduction is, the concept is that it doesn't say stop using drugs, but use it, but I will help you to use it in a safer way. For instance, he mentioned
not safer, but less harmful.
Less harmful. Because he mentioned naloxone. You understand? It is one of those activities that is embedded in harm reduction. They don't want you to get drug overdose. So they help you with naloxone. And the concept doesn't say stop using drugs. It says continue, but we'll help you to use it safely. So there's a concept in there called the syringe exchange program, where people who are injecting drug users are being supported to use their drugs in a safer way.
So you bring your used syringe and we give you a new one, so that you don't share.
So that, because in the ghettos they don't have the luxury of using and throwing the syringes away. So they will support you each time you want to inject. You use a fresh, a new one, so that you don't infect yourself and get HIV and then hepatitis and so on. So it is difficult, because I remember I attended a program where faith-based organizations were represented. And the discussion only centered on harm reduction. So at a point, one of the sheikhs got up and asked, why are you talking about helping the people to use the thing in a safer way, but we're not talking about prevention? So I can, understand where he's coming from, people. But you see, Doc mentioned something in his initial submission, that some of these people, we shouldn't see it as a moral decadence problem. It shouldn't be a moral problem. It should be like, we should consider them as people who are sick just like any other ailment. Because some may have even indulged in this because of their own societies or environment that they found themselves growing up. So it may not even be their fault at all. So saying that when that person gets to the point where he becomes an addict, we should leave the person out. I'm not saying that's what he said, but if that's what the understanding is, I don't think that is bad. Because prevention itself, the aim of prevention is to either prevent or delay the person from, like Doc mentioned about, there's a certain level where if you get to and you still use drugs, it will be better than using it at a very early age. And part of it is to help the person from developing into, a substance use addiction.
So we have two recovering addicts who we'll be hearing from later, and I think their perspective will be helpful.
I also want to say that what Prof said, I share in that perspective as well. I'm not sure he was saying that we should not do any treatment at all, no. But for me, like I said, I was ignorant. But when I got into this space, into this ecosystem, and then the discussion started, I believe strongly that one of the key things that we can do is to use prevention. And also the argument of how expensive it is. And we all know the challenges that confront our various health centers. We don't even have the facilities. And so if we can be big on prevention, no government or nobody can rule out treatment, because you will definitely have addicts living within our midst. And so we cannot entirely do away with treatment. But the country must have a comprehensive program for prevention. Because if we're able to do that, even the awareness, when there is more awareness in the spaces we find ourselves, we're able to help prevent it from happening. And so I support the idea of we being big on prevention, but treatment cannot be ruled out.
Kwame Sapon-Siedu, I deliberately waited to come to you on this because I noted a particular statistic when Kofi was with us earlier. From 2020, where some 5.7 million milligrams were seized, we jumped to 15.5 million in 2021. And then in 2022, it went to 59.9 million. 15.5 to 59.9 in 1 year. I'm scared to check 2023. But from a policy perspective, are we probably nowhere near even scratching the surface of the actual size of this problem?
It's good to listen to my colleagues, and I enjoy listening to my colleagues, especially when you have a minister who's so committed and showing commitment to the problem. But the irony is, if the minister is so ignorant, and I use ignorant advisedly because I'm not saying he's an ignorant person, but he was saying that he wasn't well educated. And not being well educated is a sign of ignorant about the gravity of the problem. The first question I ask before I answer your question is, in 2015, I was part of a Joy multimedia national dialogue on opioids. And you can check it, Kojo. When the tramadol issue came up, and when I was invited for this program, I actually turned the invitation because I was like, after 10 years, what else does anyone expect me to say? And I have checked the panelists. Olivia, who is my mate, who used to head the tobacco center at FDA, was on it. And Simmons from Pharmacy Council, who is one of the directors at Pharmacy Council, was on it. As well, Olivia happens to my mate. Simmons, I taught in pharmacy school. So I was like, if after 10 years of a national dialogue, we are none so wiser, what does anyone expect me to come and say today that is going to shift the needle? And that was why I turned the invitation down. Because Kojo, ordinarily I wouldn't turn an invitation from multimedia down. But I did on this occasion. You can check with your team. But then they came back to me and I looked back and I was like, I saw another advert, which was the Joy program that was aired on Monday. And they were saying Unim Red was Tramadol 225 in that program. And I laughed because I went back and I watched the 2015 program and 225 was available then, 10 years ago. And I did explain tolerance and dependency in detail from a pharmaceutical chemist standpoint, because I'm a pharmaceutical chemist, to say it wasn't popular at that point, but we would get there because of the dependency threshold. Because I'll do a bit of basic science. Tramadol is an opioid, yes, but it doesn't act on the main opioid receptor. It acts on what we call the gamma immune receptors. And I did say that in 2015, so I can say that, which are divisive opioid receptors. They deceive, and that is why you were shocked that they can give you euphoria and at the same time can give you enhanced erection and can give you duration. Because those receptors are habited, and I'm glad I've got colleague pharmacists in this, but what we call partial agonist. You can trigger them to some point and you can block them to some point depending on what you want to achieve in the treatment pathway. So, for example, if you have intense pain and you think those receptors are the causing it, you block them. And you use what we call, sometimes you use muscle relaxants and all that. So the truth of the matter is, why I'm saying this before I go to answer your question is that the Unim Red, and one of the panelists in the studio has answered it, is actually not 225. It is tapentadol cariciprodol combination, which is what I warned we would get to 10 years ago. Because cariciprodol is a muscle relaxant, and tapentadol is a class 2 opioid, which is not a deceptive. It acts on the main opioid receptor. In my practice as a pharmacist, in over 25 years, I've only seen 2 patients on tapentadol, and that was in the UK. 2. because of its excessive addictive tendency. So when I watched the BBC documentary, and I remember, Kodo, you spoke to me on that on the Super Morning Show, and I told you I was scared. And I remember my conversations with you on WhatsApp, which I said I wouldn't have publicly because I didn't want to trigger concern. But I clearly explained to you how tapentadol works in a step-by-step mechanism. And I remember your reaction when you eventually picked the phone and called me. You were like, Kwame, but why then do we have this drug on the market? And I said, the irony is it is more used in the galamsey centers. And I asked you to check with my friend and your colleague Erastus. And you got confirmation that that was what was happening. So the truth of the matter is, Udin Red is not tramadol. A lot of the people are giving the impression that it is tramadol, but it isn't. So now to your question. And I would answer your question this way from Prof's point. I have happened to practice in the UK significantly and in the European Union and Ghana. And I have seen different approaches to addiction management. I've seen the Holland model, which is what we call the open access model, where they actually create use centers. I've seen the UK model where we do the needle exchange and we do methadone and exchange and other things. And I've actually, at a point in my career, operated when I was director of pharmacy operations for Boots UK, one of the biggest drug exchange programs around the east of England. So what I'm telling you is what Prof said is not palatable, but it is not too far from the truth. You can check the data. I know people who have gone on treatment programs. When I first took over as director in 2006, and I'm talking in 2025, and sometimes I visit branches of Boots because I've moved on, and they are still coming in for exchange. You are talking of 19 years later. So I also understand, Dr. Dodoye. The question you ask yourself is, if these people were not on a treatment schedule, what would have happened to them in this 19 years? What other diseases would they have spread in those 19 years from using contaminated needles and TB, HIV, and all? So there's a thin line we are treading here. And that is why, for me, policy-wise, we need to concentrate on prevention, because once you drop in that net, Kojo, check the come out rate, the number of people who exit as addicts who get even when you go to Hollywood, amongst the very, very affluent addicts, how many of them don't we hear die of overdose in their bathtubs and other things in their houses when they can afford the naloxone? They can afford all the antidotes because they are multimillionaires. But these drugs are so wicked. We saw Michael Jackson. People forget that we have the thing of Elvis Presley. We have Marilyn Monroe. You see, you need to read addiction history to realize the gravity of the problem we are dealing with. And that is why, for someone like me, who is a practitioner and a policymaker, I always say the priority should be prevention. There must be treatment, but treatment success is very low. And that is why I'm saying nobody is giving the wrong answer to the right question. All the answers are correct. But the point is, I am someone who deals in statistics. What is the success rate of prevention policies? And what is the success rate of treatment policies? And you can check it. You realize that treatment policies have under 10% rate of success. We are all professionals here. Prof knows, Dr. Dodoye knows. The only good thing about treatment policies is they prevent a cascading effect, whereby you do not give other diseases to other people, especially in the ghettos and other things. And so I would end this way. You see, we have waited for 10 years from 2015, when the last policy was ended, to 2025, when we are holding this. We have seen a country gravitate from tramadol 100, which was the predominant dose in 2015, to tapentadol. We have seen data from the United Nations Office of Drug and Crime in Dhaka, which tells us that the jihadists, a lot of them, especially the suicide bombers, often, as part of the debris they find in investigation, they contain these opioids. We have heard them encroach to our border. What are we waiting for? What are we waiting for? We have seen the impact of these things in Galamsey sites. Look, I've watched a lot of videos that Joy shared, Erastus shares, and other things. And people are arrested in Galamsey sites because others ran and they couldn't run. And when they speak, I realize this guy's high on something. I am not there to take a drug sample in the days when I used to work as a drug analyst, and therefore I did these things on HPLC and infrared to say that this guy's high on something. But the language, the coherence tells me they're high on something. And when I put two and two together, I know William Red, and I know it's a red problem. And that, for me, is what I want everyone to draw his attention to. So we are dealing with something that as a nation we have failed to address for 10 years. And that is how I want to end.
Thank you for that. And I have no doubt we'll be exploring a lot of what you've suggested in just a moment. But I want to bring in two gentlemen who I'm very, very glad we have as part of this conversation. Walter Damien and Alan Menz. Now, Walter is an internationally certified addiction professional educator. And Alan is a counselor at the Iris Place Rehabilitation Center. Both of them are recovering addicts. Good evening to you both, gentlemen. I would like to start with Walter, if I may. And I guess if we have you, we should be able to get an idea of what this is like from the inside. So first of all, help us understand, how easy is it to recover from drug addiction?
Good evening to you all, and thank you for having me share my opinion on this issue. All protocols observed. Coming from the standpoint of having treated people with substance use disorders, as we more professionally refer to them as, I would like to let viewers and the panelists alike understand, because we have said a lot so far, but a profound statement I would want to make is that when all of you are talking to these people, and I mean the people who are still using, who need the information, the people we are trying to help, at the back of their mind, they are saying, you don't really understand how I feel. So there's a very profound statement in one of our treatment models that says there is no therapeutic value of one addict reaching out to another. What I simply mean is the fact that I used drugs in the past, I have been on the street, I've been where they are in life now, and I've been able to come out of it for almost 12 years now. When I am talking to them, they understand better. Right. Now, back to your question, where you are asking, if I understand you clearly, how easy it is to come out of drug addiction. I realize that the panelists have been juggling between prevention and treatment and all that, and this question looks something like it. And I'm happy the greater number of them said we have to look at both of them, prevention and treatment. Now, when we look at the success rate of rehabilitation centers, it's going to depend on a lot of factors. So we have success rates ranging between 40 to 60%. And as for prevention, sometimes it's difficult to measure. But what I know is that when we started the main facility where I work, the House of St. Francis Rehabilitation Center, we did a lot of, we created a lot of awareness and advocacy, where we went to churches, we went to institutions, and we were telling them that, oh, if you are addicted to drugs and alcohol, we can help you. It wasn't too long before we realized that our facility was full. We couldn't handle the numbers. Then we realized that no, we had to use a different approach. Then the approach was, we are going to tackle it more from prevention rather than treatment. Now, back to the main question where you are asking how difficult it is to come out of addiction. It really is because this is a thing that hinges on the brain, on the mind. You see, even though it is a disease, it is not only physical, where you can take some injection or take some medications and then the disease will go away. That is why most of the treatments has to do with psychotherapy. It is working with the mind. So a person comes to rehab, we do the medical detoxification and all that, washing the person's system clean of all the drugs. And you would have wasted a lot of time and money if you let the person go at that point. So we require that the person stay in the facility for at least between 3 to 6 months to go through psychotherapy, which is going to work on the person's mind. Now, having said this, it is really difficult for somebody to come out of addiction because we are dealing with the mind. Now, it is the mind that is sick, and it is the mind that we are also going to use to treat itself. You can imagine how difficult that analogy is.
Right. Do we still have... Oh, right. I think we may have lost our connection to Walter. Let's see if we can re-establish that. But Alan is with us. And Alan, I mean, let's extend the theme a little bit. You are a recovering addict yourself. Of course, you're sober, but the suggestion here is that once you've been an addict, the struggle remains. Tell me about the daily reality of recovering from addiction.
Yeah. I'm switching to the... Yes.
Right, we have Walter back.
Yes. So
okay, good.
If the host can hear me,
we can hear you, Walter. Please go ahead.
Yes. So, like I was saying, you are using the mind to treat the mind. So it's it's a difficult situation. And I have seen people who come out of rehabilitation centers, they don't even get home and they relapse. They don't even get home and they start using the drugs and the alcohol. Meanwhile, they would have stayed there for as long as maybe 6 to 9 months or even a year. They are just leaving rehab and they are relapsing. So it's a very dire situation. We have to be very tactical with whatever approach there is. And for me, I think maybe we need to move away from a lot of dialogue and using all the technicalities and all that, and then get the information onto the street, to be able to help the people out there, because that is the only how we can reach the people at the grassroots. Now, one other thing I want to say is that the numbers with people using tramadol and other opioids is increasing because we have to look at it this way. If I have to go to the ghetto and smoke weed and I'm smelling of marijuana, and then there's just a pill that I can keep in my pocket and take it anytime to get even a feeling that is greater than what I'm getting from the marijuana, then why not? So that is why we are moving away from the rudimentary, if I can say that, rudimentary drug and alcohol use to using opioids like tramadol and the likes. Yeah, so this is what I can say.
Thank you for that. Let's bring in Alan. Alan, I was curious to know about, I think we may have lost Alan. Forgive me, we'll see if we can get him back. But Walter, let's get personal. I mean, tell us about the daily struggle of recovering from addiction from your perspective. You say that you've been a recovered addict for about 12 years now, you said?
Yes.
Yeah. Tell us about your
one
personal...
of the main struggles is, yes. One of the main struggles is the stigma. One of the main struggles is the stigma. So you realize that even though you have stopped using drugs and alcohol, it is not everybody who knows this for a fact. And so people have tagged you, and you know, they are thinking that you are still that kind of person. And when you use drugs and alcohol, you exhibit these behaviors where you tend to lie a lot, you tend to steal, you tend to cheat, you become a moral deviant. And these are the signs of a person who is using drugs. So I have stopped using drugs for so long now, but sometimes people who don't know me well, but only know my past, are still tagging me with that kind of behavior. Those are the daily struggles. And you see, using drugs and alcohol is usually sort of something that you do for a very long time in your life. So one of the main struggles is reintegration back into society. I mean, getting a job and all that. You haven't been able to keep a job all the while you have been using drugs and alcohol. So you are able to stop using drugs and alcohol, and settling in a job becomes very difficult. You know, gaining back the trust of family members. These are some of the struggles, the daily struggles that people who are coming out of addiction is facing, if I get your question right.
Yeah.
Yes.
How do you help people in such a position? What are some of the practical things that we could all do if we know recovering addicts to make their journey easier?
Yes. So what we can do is to, like we are saying, through the same psychotherapy, make these people understand that they need to get a different perspective of life. Their interpretation of reality has to change. Now that we have stopped using drugs and alcohol, the way we see things have to change. Another person's opinion about us would not matter to us so much, so far as we know that we are doing the right thing. So you sit somebody down and you explain to them in this regard, and they can really appreciate it, right? But if they have the same mindset, it is going to be problematic for them. And these struggles that I listed in the previous answer can also lead to a relapse. The person feels that I have been rejected by society. I don't even know how to handle family members, to handle the public, to handle colleagues at work if I have just gotten a job and all that. And it can lead to relapse. So all these are usually incorporated in relapse prevention strategies as part of the programs. Yeah.
Right. That's insightful. Thank you. Back here in the studio, I mean, we started this conversation from a position of education and trying to understand, the fundamentals of this problem. I believe just before we come back into the studio, we have got Alan now joining us on phone. Alan Menz is a counselor of Iris Place Rehabilitation Center. He's also a recovering addict. Alan, thank you for your time with us. Forgive us, it seems we've lost Alan again. We will solve that problem and get him to participate in our conversation. Back in the studio, though, we started off understanding the size of the problem. Now we want to start thinking towards solutions. But the one thing that we haven't really touched on is the growth rate of the problem. And I hinted at that when I was talking to Kwame Sapong-Asiedu. In 1 year, we went from 15.5 million grams seized to 59.9 million, right? Now, this can't just be a function of superb policing. It's clearly a function of, increased, abuse. Now, 2023 is probably going to scare us all to death, but do you feel, and I'm starting with you, Dr. Dodoi, do you feel that the government has a clear enough picture of the size of the problem? We've heard from the minister some of the initiatives that he's initiated since he became enlightened on the issue. But do you feel that just as a unit, government as a whole is addressing the opioid problem in a way that is proportionate to the size of it?
So globally, whatever problem we identify in substance abuse or substance use disorders, we always think it's the tip of the iceberg. My students will tell you, if they tell you they are using one bottle of alcohol, multiply by 10. They never tell you. So we never seem to know the true picture, and no government. The US would always estimate their problem, then they will go and find there has been this huge haulage somewhere. So you never know the extent because most times the traffickers are ahead of the enforcers. So we don't. What is important to solve it is that, as they say, as the hunter learned to shoot without missing, the birds have also learned to fly without perching. We can't use the old ways to manage substance use disorders any longer. We must change. And unfortunately, which I'm part of, the problem is that we haven't changed the syllabi that we teach our health training schools. We are still big on hypertension, diabetes, infections, malaria. We still teach leprosy. Even though I can bet myself, no doctor probably have seen, any new leprosy in the past 10 years. But we still are big on leprosy. We've not shifted away from the fact that addiction is now our problem. So let's increase addiction in our training institutes. So we need that refocus to help the trainers. Then we need that focus even in our health education to not the one in the, like to the professionals, but in our general education when we preach vaccines like the sexual diseases, we preach maternal health, we should preach addiction as well because it is now come to stay with us. We have to solve the problem. And we can't solve it really, like you said, without knowing the scope and nature of the problem. For the past 15 years, I must say, we've been part of UNODC, that is UN Office on Drug and Crime. They have an African office, AU office. We have the West Africa, WENDU. They've been advocating that every country must get a national registry of drug addiction. And it's not something so huge. We have it in TB. When you have TB, anywhere in the country that you go, we know you would, get you to a server somewhere. So it's something which is doable. We've done it before with TB. Yeah, why don't we do it with, the drug abuse? So that we know where these people are, we know what are their ages, we know what they do. Because until we really have data to understand the problem, it will be difficult to solve it. As at now, we are just using the general approaches known. They are not specific to Ghana because we don't know the Ghanaian problem. And that is what I'm happy Honorable said that they've actually commissioned a whole research institute to look at the problem. And I'm hoping that after that, we know that, because this is from sampling, we'll now have a census, a national one, where everybody using drug, we track them, not to punish them, but to get them help. And then we know that, because the sad part is that it's a disease of young people. So young people get into drugs, they never get training. So by 10 years' time, when you want to help them, they have no skills. What do you want them to do? They can only steal more and rob us who are working to buy more drugs. So it is not their problem, all of us. Because when that person is using drugs, he will steal from me, he will rob me, he will kill me, he will maim me. So it should be, and in Western Africa, in Guinea-Bissau, drug laws change hands, and they had a coup d'etat. We've had a certain MP arrested for drug trade. So it is not somebody smoking, taking red, which is a problem. It's a national crisis. It can change politicians. It can change who rules you and I. It is not a small problem. It can actually attack democracy. The very institute that allow us to come and sit here. If we don't tackle it, it will rob us, all of us.
Right. I think we are joined now by Alan Menz, who, of course, is a counselor of Iris Place Rehabilitation Center. He's also a recovering addict. Alan, thank you for your patience. We've been dying to speak to you and get your perspective on this matter. Maybe you can help us from this angle. How easy is it today for a young man like the ones we saw in the documentary, the ones who actually want help to combat their addiction? How easy is it for them to get that help? Alan, do we have you on the line?
Yeah, hello, good evening.
Good evening, Alan. Would you like me to repeat the question?
Yes, please.
Right. I'm asking, from your perspective, how easy is it for addicts who want help to actually get access to help in combating their addictions?
Good evening, panelists. Good evening, viewers. All protocol observed. Accessibility to treatment centers is easy, but the cost of treatment is so high. Sometimes you get persons with substance use disorder knock at the gate of the facility. They want treatment, but they don't have what it takes. They can't pay for it. However, those who have what it takes to check into treatment should have certain qualities that would ensure a successful treatment program. One, they should be willing. Two, they should be honest about their situation, that they are powerless over their addiction. And then they should also keep an open mind. They should allow themselves to be teachable and also learn new ways of living. The problem of the addict or the person with the substance use disorder is basically not the drugs per se. The drugs are only symbols. The underlying conditions of all addictions are emotion. The person, so for instance, in my case, I have learned how to live with myself, how to live with others, and how to live with God. You change the way you react to situations. Because I keep saying that one's drug of choice will not fly in a golden tray and say, here I am, take me. It is our conditions that sets us up. So the entire treatment program teaches the addict a new way of life. But having learned the new way of life, then there's the question of the obsession that one has to deal with. Because we say it is a disease of the mind and the body. It's a disease of the body because when you take it, you react abnormally to it. You exhibit the physical allergy. But when you are not using drugs, of course, you live with a mental obsession. And it is only by, keeping a task, learning how to handle and control your emotions and practicing honesty, keeping an open mind, gradually and with time, your commitment, because all persons with substance use disorder, they need treatment, but it is not all of them who want it. If you want it, you would get it. And that change we want doesn't happen overnight. It takes time. So basically, this is what I can say for now. Thank you.
Right. So how did you do it? I mean, take us back, if you can, to that moment what is it that even made you decide that you wanted help? And how did you go about accessing that help?
All right. So personally, I hit rock bottom, and I said to myself that there's a better way I can live my life than how I was living.
What was rock bottom for you? Alan,
come again?
Describe for us what was rock bottom for you.
Rock bottom, I was on the street. I had lost family. Not that they were dead, they were around, but I couldn't go to them because I was always a horrible sight when I got close to family. None of my friends wanted me around. Anybody who had been giving me pittance here and there to sustain my addiction, they were all fed up. Then I realized that I had to initiate the change myself. Of course, I kept praying to God, but like you said, it's easy getting in, but it's very difficult coming out, especially to deal with the withdrawal symptoms. Then finally, my eureka moment was when my sister agreed to check me into treatment, and I was privileged to undergo detoxification. So at least 70 to 75% of the withdrawal symptoms was managed and handled. The rest of it is much insomnia, sleeping disorder. Initially, I experienced sleeping disorder, insomnia, for 9 months before my normal sleeping pattern was restored. Now, checking into the program, I had to be honest about myself that I had no control over the use of drugs, whether it is little drugs, whether it is more drugs, because the program taught me that 1 is too many, 1,000 is never enough. So we use the 12-step model, and step one has to agree and surrender. It is the only battle that is won. The battle of addiction is only won by surrendering, by giving into the fact that I cannot fight addiction. There is nothing like control using. I'm powerless when it comes to the use of drugs and alcohol. And until I took this step, it was difficult to gonna get it. But eventually, with that open-mindedness, I had to keep quiet, listen. The program says that rarely have we seen a person fail who has thoroughly followed our path. What is the path? The path is the new way of life. Changing my perception about life, the way I deal with people, practicing honesty in every aspect and area of my life. So with this, I was good to go. I gave myself time. I stayed in the treatment facility for 2 years, 3 months. And if you go through the 12-step program, well, you automatically become a counselor, because we say that you cannot give what you don't have. So we can only keep what we have by giving it away. So working with other addicts helped me to consolidate my foundation of recovery. So that is why Walter quoted that the therapeutic value of an addict helping another is without parallel. Nothing can be compared to that. So we identify, but we don't compare. So anytime I see a newcomer come in, it helps me to reflect the way I was when I also checked it. And like I said, helping and working with other addicts actually helped consolidate my own recovery foundation.
That's an inspiring account. Thank you very much for sharing that personal experience with us, Alan. We are still in our JoyNews National Dialogue, Breaking the Chains, Ghana's opioid addiction. I think it's at that point now where we can start thinking about solutions. And that's exactly what we're going to do when we come back from these messages. Stay with us. You're welcome back. The National Dialogue on Joy News continues. We started at 6 o'clock and we started to dig into breaking the chains of Ghana's opioid crisis. The conversation has been engaging. We've been hearing from Ada Alotepapo. She is a head of Substances of Abuse Department at the Food and Drugs Authority. We've also had contributions from Chief Superintendent Dr. Birgit Nuro Penyin. She is a law enforcer, of course, and a psychiatrist at the Ghana Police Hospital. Dr. Eugene K. Dodoi is lead addiction specialist and the acting chief executive of the Mental Health Authority. Kamaldeen Awudu is head of education and prevention at the Department of Narcotics Control at NACOC. George Opariado is the Honorable Minister for Youth Development and Empowerment. And we've also been joined via Zoom by Dr. Kwame Sapong Asiedu of CDD, Professor Samuel Ajololo, who is head of Department of Mental Health Nursing at the University of Ghana, and Walter Damien, who is an internationally certified addiction professional, educator. Also, Alan Menz, who is a counselor of Iris Place Rehabilitation Center. Of course, both Walter and Alan are recovering addicts, and it's been an insightful conversation so far. I think it's time we started turning our attention towards solutions and the way forward. And again, I would like to start with Ada, if I may. And I'm interested in an aspect of the conversation that we haven't yet touched on, which is the fact that some of these drugs are not only available through the black market or through illegal importation, but over the counter in pharmacies. What would you say should be the simplest and most straightforward way for our society to tackle the problem of legally acquired harmful opioids?
So the FDA for these controlled substances has a system in place to ensure that they are not being diverted for illicit purposes. So all importers and manufacturers of such products require a special permit. And after we've issued them with this permit, when they distribute these medicines, they are required to give us their utilization records, which will do follow-ups to ensure that wherever the products were supposed to go to, they actually reached those people. Although these measures are in place, we sometimes do have some challenges. By law, only pharmacies, hospitals, clinics, and over-the-counter medicine suppliers are required to dispense medicines. But for these category of medicines we are talking about with reference to opioids, over-the-counter medicine sellers are not allowed to sell these products. So when we do monitoring activities and we identify that they have some in their facilities, we actually sanction them. There are regulatory sanctions available.
What's the sanction?
Okay, so there are fines and prosecution. But I think this year, or latter part of last year, we had a case in Bono that the over-the-counter medicine supplier has been in prison for 15 years. So the laws are there. And now we also notify Pharmacy Council that is responsible for issuing license to these facilities. And so the pharmacist in charge of that pharmacy, your license may be withdrawn, you'll be sanctioned, and the license for the facilities may be withdrawn as well. So these are some of the measures we've put in place to help control the diversion of these substances. And we also do a lot of collaborative joint inspections with Pharmacy Council. So now we are going out with them more to the facilities to check to make sure that these products are being controlled as required by law and the regulations that we have provided.
Let me bring in Chief Superintendent here. What one thing could happen to help your success rate in dealing with the opioid crisis from the law enforcement angle? What one thing would make the difference for policing?
I think stronger interagency collaboration. It's not a police or customs or FDA. It's not one organization that is going to tackle this thing. So I believe that stronger interagency, interorganizational collaboration would go further in the management and the tackling from a law enforcement perspective. We spoke about it coming in through borders. We've got our customs, we've got our immigration. We've spoken about the selling on the streets. We've got our NACOC, we've got FDA. She's brought in the Pharmacy Council. So it has to be a collaborative effort because police can go in for a swoop, which we tend to do, gather everyone around, take them to the station. If nobody talks, we are virtually stuck. And once again, as I said, a user has the least punitive punishment versus a trafficker. And so once we collaborate with everybody, I think it will go much further in the tackling of the situation.
Would the bail situation, if that were changed, would that help?
We have to be conscious of also human rights and a lot of the human rights organizations and things with charters we have signed as a country. So when we are talking about law enforcement, we are no longer looking at so much punishment with certain cases, with certain situations. We don't want to be seen as heavy-handed. We want the society to recognize that, yes, we always say police is your friend. So in the management of these things, we don't want a situation where we come in hard and heavy. We have seen in the past that these have not necessarily helped because it just makes people go very much underground. So we have to take into consideration the human rights of people. So I wouldn't say the bail situation would significantly change what is happening. But definitely, as I said, the collaborative aspect would go a long way.
Kamaldeen, you concern yourself a lot with prevention. It's actually in your job title.
Yeah.
And you have a very clear picture of some of the push and pull factors around addiction. So what have we not done yet? What are we yet to try? What outside the box thing can we attempt with hope of getting some traction in breaking these chains?
Yes, thank you very much. I think that there has been something we've been advocating for a very long time, and that is inclusion of substance abuse prevention studies in our classroom curriculum for a very long time. There's something briefly mentioned in there, but we want it to be mainstreamed so that it will become part of the schedule in the school for their studies. So it doesn't look like NACOG or FDA goes in a one-off, does education and then goes back. But if it is part of the school curriculum, I think that will help. And then teachers will be well trained in terms of prevention, and then they will intend teach the students. So I think that if that happens, it will go a long way to help in the fight. And let me also mention, let me just, the Honorable Minister mentioned something about the bones, people using the bones. What we have gathered from our research is that, in Sierra Leone during the Civil War, after the Civil War, a lot of the youth in the country became so disgruntled, hopelessness, and so on. So most of them used drugs as a coping mechanism. But because of the situation then, they were not even economically, in that they didn't have the economic capacity or the financial capacity to even afford the drugs. So what they did was that they dug graves, and the idea was that formalin, they think formalin has some psychoactive elements in them. When it is used to preserve dead bodies, and they believe that even after death, formalin still exists in the bones somehow. So they dug the bones, grounded them, and then they found any leaf at all, because they couldn't even afford maybe cannabis or any other drugs around because of the situation after post-war situation. So they did that, and that's where the Kush, the Sierra Leonean Kush, started from. So they mix any leaf, any dried leaves, grounded it, and mixed it with the bones, and then they took it, believing that the formalin in it has a certain psychotic substance that gives them a certain high. And so we did a study, I think about a few years ago, and then we wanted to find out whether the issue of Kush had actually, is actually happening in Ghana. But we realized that Ghana also has our own version of the Kush. Just let the minister know why, apart from what Doc said. But just to end my submission, you know, like I said in my initial presentation, the risk factors are the most important, because if you leave the risk factors and then you jump into the middle, you may end up not achieving your desired goal. One very serious risk factor is what we refer to as major transitions in a child's life, like maybe moving from the safety or security of the home into school environment, like moving from senior high school into SHSs. That is where the kids leave the security of their home and they meet friends from different, value systems. And that is a very high risk factor that exposes them, into a substance initiation. So what we do as an agency from Narcotics Control Commission is that we preach family bonding. If you listen to the Irish policeman, he was talking about even though his parents were alive, he left home. That means there was not that parental bonding. That tells you how important parental bonding is, a protective factor for drug use. So we preach that parents should know the whereabouts of their kids. They should know their friends' whereabouts. The concern, when they come and complain to them our issues, they should let the kids know that they are concerned about their issues. Some of these things seem very trivial, but are very, very important when it comes to substance abuse prevention. So parents, if they are listening to me, they should know their kids' friends, their whereabouts, be involved in their learning, especially because kids who do not have school attachment also have a very high propensity to engage in substance use. So in the Narcotics Control Commission, apart from the enforcement aspect that we do, we emphasize so much on prevention. But unfortunately, in our part of the world, we don't decipher between awareness creation and prevention. Awareness creation or education is just go in there, provide the information, give the person advice so that the person can make maybe informed decisions. But it is not necessarily a behavioral change intervention. It is prevention that's a behavioral change, because these life skills are instilled in kids to change their behavior. For instance, let's use resistance skills. If the child lacks resistance skills, anything that comes to them, they take it, and it involves it will be either drug use or any other behavior. So what we talk about usually is people leaving what the root causes are and jumping into the middle and thinking that the problem will be resolved. So Narcotics Control Commission have recently intensified our both the enforcement side and then the drug demand reduction aspect. A lot of new district offices have been opened. We have intensified our operations at the border posts, and then we hope that with collaboration, like Madam says, that's the most important thing. Honorable started something very, very, very well, and I think that if we all collaborate and come together, we will end up bringing the issue to the barest minimum. It cannot be completely eradicated. Thank you.
Dr. Dodoi, you have been the loudest voice for treatment on our panel, with good reason. But how do you treat stigma, which is a really big effect of drug addiction? And we've heard from Walter talking about how that became one of the biggest problems he had to deal with as a recovering addict. How do we handle that?
So the biggest, stigma actually comes from lack of knowledge. When we don't know much about something, we stigmatize it and we are afraid of it. So, like Kamal said, if we educate and people understand that addiction is a disease and that person doesn't have a moral failure, and that the fact that he is sick is no fault of his. When people get that understanding, then they move from that stigma to support. So the biggest challenge we have as a nation is to educate ourselves. We call it mental health literacy. So when people understand mental health conditions, when people understand addiction, it's just like TB. I don't know if you recall, but in Chi, It's called Nsamanwa. And it was stigmatized. Even HIV was stigmatized. Now people are proud they can be HIV ambassadors. Yeah, so it was because of education. Now we know HIV doesn't mean AIDS. Because people with HIV live with HIV. They don't have AIDS. They won't die from diarrhea. We know that now. So nobody will stigmatize them. So if we educate people to understand that addiction is a disease, it's not, I'm not promoting people to become addicted, no. I'm just saying that some people, by their genes, their genetic makeup, when they are exposed to substance of abuse, can't stop using. For them, they will need help. And they are just as sick as anybody who also probably, just by being black and a male and tall, you are prone to hypertension. Black males are prone to hypertension and diabetes. Just by being black male. So you don't punish me because I got hypertension because I'm tall and black and all that. So we need to educate people to understand that addiction is a disease and that people are crying for help. So let's help them. And if you know, that they are ill, you obviously will not treat them as if they deserve punishment. It is difficult, I must admit, to live with an addict, to have an addict in their family. They rob you, they do all kind of bad things and all that. And we all tend to associate them with crime. Even when I was young, I thought anybody with locks smoke weed and they were criminals. That was my perception until, I was exposed that, in fact, there are people with locks who are priests. They get it. So then you change it. And the fact that somebody smoke weed doesn't mean they commit crime. And the fact that alcohol, for instance, when people take alcohol, they don't commit crime because this is cheap. The drugs are expensive. And that is why so when we understand them, we would actually move away from stigmatizing to supporting them. And that is where, as a nation, because when you travel to the West, it's a different ball game altogether. People have sympathy on their family when they have an addict because they all know how they struggle to stay well. So when we move from that position of ignorance to knowledge, we will really transform our stigma into a support. And that is what the Mental Health Authority, that is what health workers seek to preach, seek to promote, and help persons who are going through this trauma of addiction.
That's useful. Prof. Fajololo, if you're still with us, your thoughts sparked some very interesting debate amongst our panel, and I'm so grateful to you for that. But one important thing that came of it was that you were quite concerned about the capacity levels of the medical professionals when it comes to their ability to help treat those who are recovering from addiction. What would be your recommendation? How would you go about improving the capacity of those who we rely on to help addicts to recover?
Thank you very much. I'm happy to have this opportunity again and to comment on the issues that I made first, which generated some good discussions. Let me emphasize that I'm not saying that we should not treat people who are addicts. And I'm sure few people got that point. Yeah. But the main focus of my submission was the fact that we should be prioritizing preventative efforts. We should invest more in prevention than waiting for people to get to a certain level and then activating the processes of treatment. And as we have heard from our colleagues from Walter and Co., the process is not easy. The commitment and investment to get even 20% of your population to be going through rehabilitation, the financial consequences are enormous. So why would we wait for that to happen when we have the opportunity to put in measures to prevent the issue. And I'm happy that the discussion is centering on the prevention now. Treatment, we cannot. We cannot say we will not do treatment. When COVID came, in the wisdom of public health, we intensified prevention whilst doing treatment. We didn't wait for people to get more COVID before looking for treatment. No. So we have to always be prevention focused, and that is the point. Now, addressing the issue of healthcare workforce. As a nation, we just need specialists in that area. We should not presume that any medical officer or any person who just finished, let's say, mental health nursing program or psychiatry program, by that is a specialist in addition. No. There are specialist trainings that these people must have. And as a nation, we must consider to invest in that as well as we are seeking to step up the fight against opioid crisis. I did mention that at the Ghana College of Nurses and Midwives, they have started training people to be specialists in addiction. And I know few others who have trained outside the shores of Ghana and are back to the country to support the rehabilitation efforts. So this we can do. At the universities in Ghana now, I'm not sure any university has any specialist training program in addition, at least not at the University of Ghana that I'm aware of, across various programs from psychology department all the way to psychiatry to nursing. We have rehabilitation as part of the general training, but not that when you finish school, you become a specialist in addict rehabilitation or something. So we can invest some resources in those areas. The minister is there as part of his initiative to combat this menace that we're talking about. You should work with his counterpart in the education ministry to see how they can resource the institution, the universities, the training schools to begin to also produce specialists in some of these areas so that if they intend to set up rehabs for those who are already addicts, they have the expertise to run the show. Otherwise, if not, and we just recruit anybody because they are nurses or doctors, the cost may be more than we envisage in rehabilitating these people. Thank you.
Thank you. I'm saving the minister for last because, I mean, he's demonstrated a keen desire to gain expertise and, in this area. So what I'm going to do is, once we've heard from everyone, I'll have the minister give us his final thoughts on what he's picked from this dialogue and what he's going to do differently going forward. Let me focus on prevention for a moment and bring in Walter and Alan. Walter, I'll start with you, if that's okay. Is there anything that could have happened at the beginning of your addiction journey that might have prevented you from becoming an addict? Anything that we could replicate, duplicate across the country today and hopefully prevent some people from becoming addicts?
Okay. Yes. So I think in the light of prevention, we need to consider a more holistic approach on it's a family disease. Addiction is a family disease. I know panelists have said a lot that addiction is a disease, but also it is a family disease. When someone is sick, the entire family is sick. The mother becomes an enabler. She gives money to the addict, knowing very well that it's going to end up in the ghetto, being used for drugs, but she is powerless. The siblings are overly protective of their properties and all that. So whilst we are looking at helping people come out of their addiction, we shouldn't limit the treatment and education only to the addict, but also we should include family therapies in our approach. Now, as an educator, I would also advise that those of us who have if I can put it this way, had the opportunity to use drugs in the past and are now in recovery and helping others, should be at the forefront of the fight. You know, the minister and all the other experts can be in the background pulling the strings, but we can be at the point of connecting this help to the people using the drugs. And I know we all know recently the benevolence of Mr. Niyama opening the food banks have brought about some regulations. Right. Now, what I think of these food banks are that we can also open drop-in centers. Yes, and by drop-in centers, I mean there are places where the addicts can walk into and get first-hand information, all the education they need, where to get help, you know, first aid for people who are using drugs and alcohol. And also, we would need government subsidies, especially when it comes because we can all agree that it is expensive. It's really expensive to treat people who have disease of addiction. Having to keep them in one space for as long as 3 to 6 months, feeding them 3 square meals a day doesn't come. Even the medical procedure of medical expensive. So we would advise that government should step in and see what help they can offer in that direction. So these are the few things that I want to put across for us to look at that will go a long way to benefit the help that we are trying to give. Yes.
Thank you for that, Walter. I believe we still have Alan on the phone. Alan, I want you to talk directly to the streets, to those who are struggling with addiction today, those who are considering experimenting with drugs. I want you to give them that one message that you wish someone had given you at the beginning to have prevented you from going through all the turmoil that you did.
Well, thank you very much, Kojo. So just as Dr. Dodoi said, we have to learn to replace ignorance with knowledge. So a lot of psychoeducation going on out there that we don't have to try it. You know, it always starts with the experimentation. Like I said, it's always easy getting in, but it's difficult getting out. So what I just want to say is that we should fight addiction with all that we have, but we shouldn't fight the addict tough love. We should not enable them. Just as Walter said, there should be a lot of family therapy meetings going on there. But I want to assure fellowship out there, the 12-step fellowship. We have meeting centers all over, scattered all over Accra. The only requirement to join is a desire to stop using.
It would seem we may have lost the connection to Alan there.
And then find a new way of life. And thank you for having me share.
Thank you for that, Alan. Kwame Sapon-Asiedu, I deliberately kept you to this moment because in 2015, you warned us of this future. At the time, the problem was tramadol. Today, it's Wunim Red, and we're looking at 250 milligrams of it, you know, being popped by people on the streets. You saw this 10 years ago. Now we are here in 2025. Look 10 years into the future and tell us what we will have on our hands if we do nothing.
Kojo, I hate to be a prophet of doom. When I'm asked questions like this, I remember what I said in 2015, and I also remember what I said in 2019 when the Galamsey fight was starting, when I wrote an article on it and Samson interviewed me on Newsfile, and I was telling them the immediate, the delayed, and extended effects of galamsey. And all those things have come to pass. The point of a policy researcher is you do not want what you predict to come to pass. The reason why you predict them is that the policymakers and implementers will take decisions to prove you wrong. Unfortunately, my learnings in both this tramadol, opioid addiction, saga, and galamsey is that for some reason, I don't know if it's deliberate bloody-mindedness or it's a lack of understanding, our policymakers and implementers wait for these things to happen. So if you tell me now that we are at a sunset with tapentadol, when we were dealing with tramadol in 2015 and even tramadol 225 was not so much of a problem, even though it was on the market. The only logical conclusion I can make is that we would be heading towards the realm of oxycodone. And for me, that scares me. That scares me because even the United States are failing badly at dealing with oxycodone addiction. Even multimillionaires, you know it, you've seen the findings from the cause of death of Michael Jackson, I don't need, you've seen so many film stars. And every time he either fell in his bath or choked on his vomitus and stuff like that because he was overdosed with oxycodone. That scares me. Why does that scare me? It scares me because we find ourselves as a citadel of peace in a region of turmoil, where we have a lot of jihadists surrounding us. For some reason, and rightly so, we've managed to keep our country away from these jihadists. But one thing we know is that the corridor for the transportation of these products pass through Ghana to Niger. I'll share with you two names, not on air, obviously, because you and I know how we share such information, but it's known to government operators, and I'm sure the minister even knows, in Niger, who have imported tapentadol and carisoprodol, and I'm sure the representative of the FDA, because he's a director, knows the person I'm talking about, through Ghana. In January, some was seized and was banned. February, the same thing happened. And I think that was what she was insinuating when she said, the main kingpin sits out of Ghana. Because those of us who are operators within the space know the name. And we know this person is an influential Nigerian with connections to the Nigerian government. So it's not that I'm being ambiguous, it's just that I wouldn't mention the name for obvious reasons. So if you tell me to predict 10 years down the line, and we use ECOWAS protocols to allow these things to be ferried through our ports, and we know that what happens is that as they ferry through our ports, because of our citadel of peace, they tend to dump as they go through our country. And that is how we find it. So if you remember initially, when the BBC documentary came out, the FDA said it's not licensed in this country. We don't have evidence of it arriving through our ports, only for them to then turn around and tell us that they had seized some and it had been banned, but it wasn't meant for Ghana. The question then became, it wasn't meant for Ghana, but the things were on the Ghanaian markets because an investigative journalist had picked it up and people like Erastus had also picked it out in the country. How was it happening? Because of the dumping, because that kingpin is sitting elsewhere. So 10 years from now, if you tell me to predict, if we don't cut those trade routes, we'll be down the route of oxycodone.
Wow.
And that, for me, scares me.
Indeed. I'm going to give the last minute to the minister to wrap things up and tell us his way forward in his ministry, following everything that you've experienced in this dialogue tonight.
From all the discussion, it looks like we need to do more. And as a country, it doesn't take only government to deal with these issues. When I decided to conduct this research, I got Richard Nyamakwe. When we launched the Red Means campaign, he came on board, and so he funded this research work that we did. And that is what we need, a lot of individuals coming on board to support initiatives like this. Like I started by saying, this problem cannot be solved or dealt with by government alone. Everybody must come on board. I also believe that we need programs like this to be able to talk about it. It's the more advocacy that people get to hear about what is happening, and then people who have solutions. Like Walter, like Alan, these are people I would love to meet. If I had not come on this platform, I'll never hear of them. And so we need to have engagements like this to be able to bring the issues out and then find a holistic solution to it. I've always said, and I continue to say that, yes, Galamsey is a problem, but if you go into the Galamsey areas, a lot of these guys who are doing this Galamsey are people who are abusing one substance or the other. And so we need to look at this issue more critical. We should be a bit more deliberate and a bit more intentional as a people. And I will do what I can do. I know His Excellency the President is very much committed in ending or in trying to eradicate. Like they said, we cannot eradicate it entirely, but at least we can fight it and reduce it to its barest minimum. We also need to do a lifestyle audit. The law enforcement people are telling us that because of the laws and because of how people get bail, I understand, I'm a lawyer, and I know we cannot underestimate issues of human rights. But the people who import these drugs live with us. We see rich people come up every day, we don't even question where their wealth is coming from. It is time we became a bit more drastic in auditing the lifestyles of people, asking the relevant questions. When you are driving certain vehicles, we should be bold enough to ask where these cars are coming from. Because it is the same people who are feeding these things into our streets. It is not, I understand some because of the transit routes, but majority of the people who are bringing in these drugs live in this country. We know them. We must be a bit more deliberate and a bit more intentional, because this has the potential of destroying our country. Our youth is what we depend on to drive our economic force, our labor force, and what have you. And so the more this group gets intoxicated with these drugs, the challenge is that a time will come we will not even have young people to be able to support our labor force. And so as a country, let's all work together. Everybody must come on board to help us deal with it. We will do our bit as a ministry. We'll share what we have. We'll collaborate with the various agencies. But everybody must come on board because it is more closer than you can think.
Thank you so much, Mr. Minister. Thank you to all of our panelists tonight who have made our conversation so exciting. Like a citizen stumbling through Tinker Island, we are all high on the dopamine of this conversation. But I sincerely hope that as we sober into action in the coming days, we will start to see a turning of the tide as we break the chains of Ghana's opioid addiction. Thank you so much for joining us. My name is Kojo Yankson. Have a good night.